Good evening, everyone, and thank you for joining us here at the Core Institute as we discuss the latest treatment options for chronic neck pain. Before we get started, I would like to share with you a quick tip on how to engage with us throughout the presentation. We know you may have questions, so please submit them using the Q&A feature at the bottom of your screen, and we will answer questions live at the end of the seminar. Now it's my pleasure to introduce our very own Dr. Adam Lundberg of the Core Institute. Dr. Lundberg is a fellowship-trained physician specializing in interventional spine, pain management, and anesthesiology.
Hello, my name is Adam Lundberg, and today we're going to be talking about advanced treatments for non-surgical neck pain. A little bit about myself. I did medical school here in the Phoenix area at Midwestern University, and then I went to Detroit for 5 years where I did a residency in anesthesia and then a fellowship in interventional pain management before coming out back to Phoenix to work with the Core Institute. We're going to start with this presentation, and we'll kind of go over some of the common causes of neck pain. We'll move on to a lot of the common tests that we use to diagnose where the pain is coming from. And then we'll move on to conservative treatment options and then the more interventional techniques we use, including injections and basically anything outside of surgery. So, neck pain is a pretty common symptom we see in the office. 40 to 60% of all adults are going to complain of neck pain at some point in their lives. The first question that always comes up is how long it's been going on for. Anything less than 2 months we'd consider more acute pain. Whether it started off by a traumatic event, a car accident, maybe you fell, hit your head, something like that, or maybe just had a bad night and slept on it wrong and got a crick in your neck. Most of these things are, causes more ligament problems, muscle strains, things like that, and these things resolve with time. And you don't really want to be pushing or be too aggressive on pain that hasn't been around too much because you're just going to take a lot of risk doing injections that aren't going to do much. However, when pain starts lasting more than 3 months, that's when we start considering it to be a chronic problem. Obviously, if you got a worn joint, that's not going to improve over time. If you got a herniated disc, something like that, that's going to take a long time, and you might need more aggressive treatment plans than just watchful waiting. So a lot of neck pain, we've all had it, aches, sharp pains, electric, numbness and tingling, pressure pains. Can be described in a lot of different ways because there's a lot of different things in the neck that can cause the pain. Before we get into anything else, there's obviously emergencies in any field of medicine. And in my field, anytime someone starts talking about having a balance problem, coordination problem, severe pain or weakness in the arms, or bowel bladder incontinence, those are severe problems and you should go immediately to the ER. That happens when you start pinching the spinal cord too much, and some of those things can become permanent if they go on for too long. So if you see on my presentation, call your physician if you're having shooting pain down your shoulder. That is also somewhat like irritating the nerve roots, but when you start moving on to like actual weakness in the arms, that's more of a serious problem that probably should be evaluated quicker than the time you can get into the clinic. So the most common cause of neck pain are essentially the muscles, the joints, the nerves, and the discs. And this is kind of the overriding idea of this whole presentation is where the pain's coming from, because every treatment option is focused on one of those 4 things. So muscle strains, like we talk, muscles are a soft tissue. They can be stretched, they can be strengthened, they heal over time. And this is where like physical therapy and a lot of those options come into play. So muscle strains, overuse, poor posture. If you have poor posture for years, that's going to cause some muscle problems and some contractions in the muscles that, it might be harder to get rid of that pain with a couple physical therapy sessions, but over time you should be able to stretch it out. It's also like actual injuries, and that's a little different because you get an injury, you can actually change the anatomy, you can break bones, you can herniate discs, but again, a lot of that causes inflammation in the soft tissues. Arthritis is just a worn joint. I wouldn't really say it's a disease or anything that you're going to catch from someone else. Just as you get older, you wear your joints over time, and just like in the neck, these things become a problem. And we call them facets. So a lot of times if you had an MRI in the past, it'll talk about the facet joints. That's essentially what the joints are in your neck. And then you got nerve pain. That's those numbness, the tingling, the paresthesia feelings you might feel down your arm. That can be caused by a lot of different things. So, you can herniate a disc, and that can cause pinched nerve. You can have joints that enlarge over time or get inflamed, and that can irritate nerves, and that can cause pain go down the arm. So, different ways to irritate the same problem. Rheumatoid arthritis is kind of a separate thing, but also comes into play when you think of like systemic joint problems, neck pain, and that's more of a condition where your body is attacking its own joints. So you get worn joints because your immune system is essentially attacking them. So that's a little different than wearing joints out, but I bring it up because with rheumatoid arthritis, essentially some of the hands and the neck seem to be the most common first places where people begin to have pain. These are kind of the common questions I get in the office. Again, how long it is. We talked about that, how it's important to kind of delineate how long it's been around, what type of pain it is, what were you doing when it started, if there was an injury, if you've had any past interventions in the past, like physical therapy or injections, so you're not repeating things that have already been done and failed in the past. You start kind of delineating, where we think the pain is coming from. Numbness and tingling, you're thinking nerve pain. If you think it's aching or stabbing, you're thinking more of joints. Tenderness, if I can push on your neck and it hurts with some mild pressure, it's most likely a muscle. It's a little hard to push that hard on your neck to cause like a pinched nerve. That's not really going to happen. And of course, what kind of medications you've already tried in the past, and how far we need to escalate on that front. So, now we're going to kind of move in more into the tests that we use to try to help figure out what exactly the problem is. And one of the first things you're going to get if you go in the office or start seeing a doctor or even a chiropractor's office is an X-ray. You're going to be looking for fractures, you're going to be looking for instability, misalignment in the joints themselves, and mostly arthritis in the joints. So if you see there, X-rays are a really good way to look at bone structures. It doesn't show discs, although you can see how much space is in between each bone, and you can kind of get an idea of how healthy they are, but you should not be diagnosing a herniated disc off an X-ray because you really can't see them. You're just kind of making an assumption on how healthy they are based on how much spacing is in between each vertebral body. You also can't see any ligaments. You're not going to see any muscle strains. You're not going to see any inflammation on an X-ray. It really is just looking at the bony structures and getting a good idea of how much arthritis is in those joints and making sure there are no, severe misalignments or fractures if you had any traumatic event. So this X-ray right here, if I was just looking at it, that's a pretty clean X-ray. The only thing I would comment on is it is pretty straight. If you notice, there's not that nice cervical lordosis that you like to see. Helps spread the weight out of your head over multiple levels, so you take off the pressure at each joint space. And that can be caused by a lot of different things. I mean, you could just be born that way. It could just be the way your posture has been your whole life. It also can be related to tight muscles or spasms in the back of the neck, causing a straightening of the cervical spine. And again, these are things you work on physical therapy and do those home exercises as best you can, because that's really what's going to be making you feel better in a year or two. The next test we get is an MRI if we don't feel the X-rays are giving us enough information and getting us to where we need to be. A lot of times you're getting MRIs to look for pinched nerves. So here's an MRI right here. I guess it'd be the left side of the screen is the front, and the right side is more the back of the neck. You can see there the different vertebral bodies. The dark spaces in between the bones are the discs. And at the top of the screen, you can see the brain, different parts of the brain, and that dark black line right down between the white spaces, that's your actual spinal cord. So that's where you're going to be pinching a nerve. This image right here is taken about halfway through, so you can get a good idea of how narrow that spinal canal is. And real MRIs, you can kind of move the pictures back and forth to see how tight it is on the sides, but obviously we're not doing that today. If you notice, the white on both sides of that spinal cord, that's the fluid and the space that surrounds your spinal canal. And on this MRI, it looks pretty clean. I got white space on both sides. So I wouldn't say there's any severe spinal stenosis on this image, but you can notice at multiple levels there are some little disc herniations. And I picked this slide specifically to show that, this patient actually has no neck pain. This was taken off for a research study, but they do have disc herniations. It's kind of hard to tell what levels they're at, probably like 4, 5, 5, 6, and you can see those little black discs kind of pushing into that white space a little bit. It's not fully touching the spinal cord, but it's not causing any nerve impingement. Now, you're going to try to correlate these images with someone's pain. If they're having pain down the arm, if it's the right arm, if it's the left arm, and you're going to try to correlate these images to if it makes clinical sense. Like I said, this patient has no neck pain and has no pain in the arms, but they do have herniated discs and they do have some little tight spots, but apparently it's not causing any problems. So there's really no need to go do any injections. And everything has risk, so you don't want to take risks and do injections if they're not going to be beneficial. So I know a lot of people get these MRIs and we're looking for specific things, and you get these MRI reports and they have this much wording on it, and there's paragraphs, and it's saying there's tight spots here and there's degenerated disc over there. But if it's not correlating with where your pain is, it's probably best to just ignore that and just keep doing home exercises and keeping the muscles in your cervical spine as strong as possible, just to prevent as much degeneration as possible over time. So that's an MRI. Another test we use sometimes is an EMG. It's electromyography. And really what this does is assesses the health of the muscles and the nerves in your arms or your legs, basically. It's not a very fun test. Usually they're putting needles into your arm and essentially measuring how well the nerves conduct transmission down your arm and seeing essentially where the pinch spot is. Sometimes people have a lot of pain down the arm. We get the MRI. Like I said, it doesn't really clinically fit what the patient is saying. And so sometimes we'll move on to an EMG just to check if the nerve itself is damaged. And if you got a damaged nerve, either from diabetes or maybe some sort of chemical exposure, and the nerve itself is damaged and you're having numbness and tingling in the hand, unfortunately, I don't think doing injections in your neck is going to help that. It's just a damaged nerve in the arm itself, and you got to treat that in other ways. So sometimes EMGs kind of help us decide what kind of treatment options are available and whether or not we need to be focused in the neck or not. So we're kind of moving on to more conservative treatments now. These are the things I'm sure a lot of you have already tried if you're listening to this lecture. And again, all of these kind of topics go right back to the idea of, where the pain is coming from. Is it the muscles? Is it the joints? Is it some sort of nerve problem or the discs themselves? So we'll start with just massage, heat, and ice. These are the most basic things. These are all related more to the musculature in your neck. Massage helps bring more blood flow to the sore muscles by moving things around and breaking up that inflammation and swelling in the joints. Heat, I would recommend heat over ice for any chronic issues. If you sprain an ankle, or if you get a crick in your neck or a sprain in your neck from a traumatic event, you would recommend ice in the more acute phase, right? Ice would constrict the blood vessels and limit the amount of swelling you're going to experience afterwards. However, heat for chronic issues, right? If you have a chronic problem, there's chronic inflammation, chronic pain, you want to try to open up those blood vessels and get more oxygen, more blood, more nutrients into that area to help that heal. Other things, of course, over-the-counter anti-inflammatories or prescription-strength anti-inflammatories. These work both in your brain to help with pain, and they help decrease the inflammation in your body. So not very targeted, but again, inflammation helps a lot with joint pain, even if you have a herniated disc. Muscle relaxants, again, like I said in there, short-term for muscle spasms. I think there's a little bit of a misconception out there. Muscle relaxants do not specifically target pain receptors. They help pain if you're having muscle spasms by calming down the membranes in your muscles. So if you're not having muscle spasms, I'm not really sure if muscle relaxants is going to help your pain overall. However, as you can see, they do cause some drowsiness, and they can increase the risk of falls if you're taking them during the day and trying to go about your daily life. However, sometimes people use muscle relaxants at night to help sleep, help relax them. And that is usually when we get a lot of spasms as well. So they are as needed. I wouldn't take them just every day just to take them, but if you're having spasms, you might take them for a day or two and try to calm things down. Opioids, a lot in the news recently about opioids. And again, short-term pain relief until other treatments can be found or things kind of calm down themselves. So not something you want to start long-term or try to avoid. Of course, we have people on long-term and chronic opioids when they don't really have many other options left. But again, there may be a role for these in the very short term if the pain is severe. But other than that, we try to limit that medication as much as possible. Muscle pain and joint pain, again, posture. This goes back to physical therapy, mindfulness of your posture and what you're doing through the day. It is a hard thing to change your posture overall if you're not thinking about it every day. So, you can see this picture hunched over at the computer. This is obviously going to cause a lot of neck pain, a lot of thoracic pain, constantly stressing those muscles in the spine. We talk a lot about the shoulder girdle and how our entire lives we're always living in a pronated world, which means our shoulders are rolled forward. We have our hands out in front of us. We're contracting the muscles in our front and overextending the muscles in the back and the shoulders, which puts a lot of pressure where they connect in the back of our head. And that can cause a lot of neck pain too. So just something to be mindful about. And my clicker stopped. I got a clicker. That's all right. All right, we're back. So physical therapy, again, this is one of the first things your doctor would probably recommend that you get started on. Again, obviously, if this has been going on a long time for decades, it might take a lot longer physical therapy and home exercises than you want to think about because these muscles do take a while to stretch out if you've had poor postures for 20 years. But physical therapy really does work a lot on the myofascial pain, the ligaments, the muscles. I tell my patients that physical therapy and it's an educational time, right? You're going to go to physical therapy, you're going to learn what to do and how to do it correctly so that when you do it at home, you do it efficiently and don't make things worse, right? So I would not say that physical therapy is really going to change what your x-rays show. It's not going to change what your MRI shows, but the more you keep the range of motion and mobility in your neck, the stronger you keep all the muscles in your neck so that you can support your skull and support your disc and your joints as much as possible. This is where the benefit in physical therapy comes in, long term, right? Just learning a quick 10 to 15 minute exercise in the morning to try to get in that good routine really pays dividends long term. But, I will admit, if you have end-stage arthritis in the joints in your neck, I don't think doing physical therapy every day for 10 years is going to change what that x-ray shows. And that's why we do have other treatments like injections and stuff. At physical therapy, there's a lot of different techniques that they can offer. There's TENS therapy, dry needling and trigger point injections, if people have heard of those. They're essentially the same thing. At physical therapists, they can do dry needling, which is taking dry needles and breaking up muscle knots in the neck or the back or wherever you're having it. A trigger point is the same thing, except we inject a little steroids and a little numbing medicine to see if we can get the relief to last a little bit further. In the end, studies show they're pretty similar. So, I always support doing dry needling physical therapy if that's something they offer. Cupping, massage, again, a lot of myofascial techniques, and if you find them beneficial, they're certainly not harmful. So this is just a quick little slide from the Academy of Orthopedic Surgeons that they give their patients for post-op or even pre-op work before surgeries. Again, just kind of the easy exercises, a lot of stretches, keeping that range of motion and all those joints as mobile as possible. Even working on core strength and back strength helps support your posture so you're not overcompensating in the cervical spine. So let's talk about arthritis in the neck. This is probably one of the most important slides I have in my entire presentation because I see a lot of patients that got neck pain. You got the pain in the trapezius musculatures, the neck, behind the shoulder blades, around the scapula. I see it every day. And I've talked to physical therapists a lot about this and what exercise they do, and they definitely stress that a lot. And people still continually get pain around that trapezius musculature, around that scapula. They get a lot of muscle pains and things in that area. And so you start thinking that, why are these people having muscle spasms and knots and tenderness and soreness in that upper back and neck area after months of physical therapy? And they tell me they've been doing the physical therapy, they've been doing the home exercises, they do everything that they're supposed to, and they might feel good for a couple weeks, and then the pain just slowly comes right back. So you got to start thinking that there's a reoccurring insult that's causing those muscles to constantly get in a rotation and a spasm over and over and get irritated and start causing that pain again. And this slide, if you see, like I said, you get a worn joint, that's not going to change. That's just a worn joint. We're talking about the spine here. We don't do cervical spine replacements like we would a knee or a hip. So once you got these joints and they're worn, you don't replace it. It's going to start causing pain over time. And if you see where the pain gets referred to, the upper joints start referring pain up to the base of the skull, maybe up above the ear, sometimes at the top of the head. The middle joints start going to the shoulder, usually not past the arm. If it's going past the arm, you start thinking more nerve pain. But those lower joints, which carry the weight of your head your whole life, starts referring pain out below that scapula, out, up into the upper back, and you start irritating those muscle back over and over, and that's what starts causing that pain. So when I see a patient in my office come in and it's giving that typical story that they keep getting these knots and muscles and there's tightness and there's just that pain right there in that left shoulder that just never goes away, and they've been working on it for months and doing everything they're supposed to, the first thing you gotta do is get a good X-ray and really look how much arthritis is in those joints. And if you see a lot of arthritis in those lower joints, you're likely just referring that pain out to those areas and constantly irritating that musculature out there. And so you do your right thing, you stretch it out, you work it out, you do all the good stuff, it feels good, and that joint just keeps sending that pain signal out to that area. So again, there are injections out there to try to stop that. And those injections are called medial branch blocks and ablation therapy. And these are the injections. They are not trigger point injections. They do not include steroids. They really target that joint pain. So you can go in and ablate or zap, or I hear a lot of people talk about burning the nerve. And what they're talking about is ablating the nerves that innervate these joints so they're not sending out a pain signal anymore. It helps a lot with that neck pain. When you look up and grind those joints together, that's the pain I'm talking about. So you don't just go in and zap nerves in your body and just hope that it helps your pain. Usually we require a few diagnostic tests to map out, where we should put these needles and is the pain really coming from your joints. So they're called medial branch blocks because the nerve that we are targeting is called the medial branch. And this nerve innervates the joints in your neck. So we go in under a live X-ray machine and we temporarily numb that nerve with some long-acting numbing medicine. Sometimes it lasts 4 to 6 hours. If you use lidocaine, you can use longer acting stuff like bupivacaine. It might last up to a half a day to a day. But essentially what you're doing is interrupting that pain signal between the joint and your brain and seeing how much better your neck pain feels for a day. I mean, if I did this injection on you and you told me your neck pain didn't really change a whole lot and you didn't notice a big difference, then we'd be pretty confident that your pain is not coming from the joints. We should not be ablating these nerves, and we need to go find some other pain generator. However, if you do get good relief from this injection, and for about a day or so, you have really good relief in your neck pain. Of course, you might have a little soreness on the skin from the needle pokes, but that deep ache pain, that pain when you look up and grind those joints together, if that pain gets significantly better for a half a day to a day, then we all feel very good about pursuing other treatment options to try to make that last longer. And that's called the radio frequency ablation, or burning the nerves that people like to say. So essentially what we're doing now is going in and targeting that same nerve that we temporarily numbed and using radio frequency nerves or needles to zap that nerve. And I specifically say zap because this procedure is not permanent. It lasts anywhere from 6 to 18 months before that nerve grows back. So we have a lot of patients that come back every year or so, telling us that the pain's kind of coming back, feels kind of like it used to before, it's in about the same place. And a lot of times we just go ahead and ablate it again without the test because we already kind of know where this is going. These ablation therapies are so that the test procedures take anywhere from 5 to 10 minutes to do. They're pretty quick because we're just kind of testing things. The ablations take maybe 15 to 20 minutes to do one side, because you really got to be careful that you're not going to be ablating a nerve that goes down your arm, or burning the nerve that goes down to your leg. You really want to make sure you're just hitting one nerve. So we do a lot of tests before we turn it on to make sure we're in the right spot and we're just hitting the nerve that we want to target. The burning itself takes about 90 seconds. Most of that procedure time is getting that needle in exactly where we need it, because there's a lot less room for error. The needle tip only burns a couple millimeters around the tip, so you really got to be pretty close to that nerve before you turn it on to make sure you get a successful burn. So that's about it. So I'm sure there are definitely some patients out there who have had this before. Again, like I said, the procedure time itself is about 90 seconds, but you should expect at least 15-20 minutes to do one side. I get a lot of patients the following maybe 3 or 4 days will have a little extra soreness in the neck. Obviously, when we burn these nerves, you can catch a little bit of tissue around there too. It can cause some inflammation, swelling. I tell my patients just a little extra ibuprofen preemptively that first day or two might kind of help that. Sometimes we put a little steroids in there before we pull the needles out. Studies would say 4 to 6 weeks after an ablation to get full effect. But I say most patients come in about 2 weeks later to get the other side done, and they can already kind of start telling the difference. There's no stitches, there's no cutting. Again, these are all done with needles. And the only thing I mentioned, sometimes in that first week or two, you feel like you got a little sunburn because we, kind of make that nerve a little angry for a while before it kind of fizzles out. These injections can be done with or without sedation. Again, this totally up to you and how much you can take. This is a picture of the actual procedure room where we do this. We got that big C-arm, that's the live X-ray machine. And usually you're kind of laying down face down, or getting our images and kind of directing that needle in real slowly. It can take live pictures. We usually just moving the needle a little bit, take one picture, move it a little bit more, take another picture, just to kind of save the radiation exposure for everyone in the room. This is not done in the hospital. It's usually kind of a procedure suite. So the other thing we'll talk about is I guess it's called cervical radiculopathy. This is the pain that's going down the arm, the numbness, the tingling, usually related more to the nerve roots, disc degeneration, herniating a disc that's touching the nerve, or a flared up joint kind of irritating a nerve root. And I think it's really important to start thinking about, why you have this pain. As you see there, obviously you hit different nerves at different levels. It presents itself in different ways down your arm. So that's why we were always asking in the office, do you feel it on the outside of the arm? Is it the inside? Which fingers is it? Carpal tunnel would be more these fingers, but you're pinching the nerve in the wrist, and doing injections in the neck is not going to help that. But if you really are irritating the nerve roots in the neck, that's where you start thinking about doing epidurals. These medial branch blocks we've been talking about, the ablation therapy, that does not help pain going down the arms. So like I said, this radicular pain, this pain going down the arm, can cause by disc herniations, can cause by joints. It's usually not caused by myofascial pain or sore muscles or anything like that. Those muscles are just too far away to cause any problems there. So here's a picture, just like the MRI we showed before. You see that spinal cord right down the middle. You got the white space on both sides. And right there in the middle, looks like it's about 2, 3, 4, 5, about 5, 6 level. You got that big black blob that's just kind of occluding all that white space in the front. That's a pretty good disc herniation. And you're squeezing that spinal cord. Those nerves are trying to get out in between those bones and go down your arms. They're trying to wiggle their way around that disc herniation. That herniation is going to cause a lot of inflammation and swelling from those nerves rubbing in that tight spot. And that whole area is going to get real tight and causes a lot of pain, obviously. So, in this patient, as I look at this, if he's telling me he's got pain down the arms, I say, okay, we have an MRI imaging that correlates with his current symptoms, and we're going to do some epidurals and see if we can help his pain. Now, if I do 3 epidurals on this patient, his MRI is still going to look the same. It's still going to have a big disc herniation right there. And if that herniation is large enough and it truly is pinching on the nerve, I don't know if my epidurals are really going to get him too far. That really becomes more of a surgical problem. And if we can at least control his pain long enough for that disc to kind of heal up over time, maybe he doesn't need surgery. I certainly have patients who come in and we do epidurals. We've been messing around for 6 months. There's still a lot of pain. It's hurting them every day. There is a role for surgery in certain points where you have to change what an image looks like. However, the vast majority of patients I see, I would not say that it's this bad of a disc herniation. A lot of times what happens is you get a little herniation. You might still have some little white space on both sides. It's not actually touching the nerve, but you get a little tear in the disc, you get that inflammation and swelling, and that's exactly what steroids are designed to do. These epidurals that we do is injecting steroids back around that area, and steroids are really strong anti-inflammatories. That's how they work. So they suck down all that inflammation and swelling that's making a tight spot feel any tighter, and people feel a lot better. Let's see if I got a picture of that. I guess we're going to talk about a little medication first, just to take a break on the injection side. So there's only 4 classes of pain medicine. There are nerve stabilizers, gabapentin, it's a pretty common one and actually a pretty good one. There are anti-inflammatories, there are muscle relaxants, there are opioids. So the nerve stabilizers, gabapentin, sometimes people go into Lyrica. It's been shown to have a little bit less side effects, but by all means is very similar to gabapentin. And then there's some older medications like nortriptyline and amitriptyline. Most of these medications are used for pain that's radiating down the arm, that nerve pain, but it's not a very good option when you think of that acute pain, when the pain is really severe. It takes weeks for these medications to really become effective. But certainly when you have people kind of maxing out other therapies, I think there's a great role for them. Anti-inflammatory medication, always a good option, does work in the brain, also helps the inflammation. And like I said, when I do these epidurals, putting steroids back there, steroids are anti-inflammatories. They just work better because they're stronger and I'm putting them right back on the nerve, as opposed to you taking a Aleve or an ibuprofen that goes throughout your whole body. Muscle relaxants we talked about, a role for it if you're having spasms. Not really sure how effective they are for pain relief that's not related to a muscle spasm though. And of course there's opioids as well when the pain gets really bad and when we're looking for short-term fixes. So here's epidurals, we'll go back to that. Again, it reduces the inflammation in that canal. We do typically a series of 3. That's because you can't inject so much steroids at once or you start running into other problems. So we try to spread it out as long as possible and keep that inflammation and swelling as controlled as possible to allow your healing process to take effect. So we're just trying to try to stretch out that therapeutic effect as much as possible. After that series of 3, typically your max treatment option at that point is 1 epidural every 3 months. You really shouldn't do any more than that. It starts getting to be too much steroids for your body. And so, of course, if you did 3 epidurals and you still feel the pain is severe, you can't sleep, I mean, that really is the time to talk to a surgeon. I guess the next question would be is, if in 3 months, do you still get the epidural? It's totally as needed. Less is more in this case. So if you do a series of 3 epidurals, that's kind of the max effect I would expect epidurals to give you. If 3 months later you're still doing good and feel your pain is well controlled and over-the-counter pain medicine, I see no need to repeat the epidural. Maybe you go another 3-4 months, it's 6 months down the line, you feel the pain starting to come back in the arm, maybe you do 1 more and kind of boost it a little bit, but you kind of play it by ear after that. Again, epidurals are done under the Xray machine as well, not something you would want to blindly stick a needle back there and kind of hope you're in the right spot. I think I have a picture right here. In these cases, you do use contrast before you inject the steroids to make sure that you're actually getting good flow in that space and that your needle is exactly where you think it is. So if you see on that picture on the left, that's the needle in the middle. You see that black line that comes across, that's the tubing from the contrast, and there's a little black blob there. And you can see that same blob on the picture on the right. There's a black line going up and down right where that needle ends in the canal. That's the contrast. So you inject that so that it'll show up on your X-ray machine and you can see where that medicine's going to flow. So again, you don't want to inject the steroids if it doesn't look like it's going to flow in the right direction. So this is a great epidural. It looks fantastic. It's going up, it's going down. He's dead center in the middle. Again, it's nice epidural there. So this is cervical spinal stenosis. I know we talked a lot about how you can get that radicular pain, that pain in the arm when you get a disc herniation. Spinal stenosis is essentially the same thing, except this is just when you get your entire spinal canal starts just getting too small. And, people always ask why you're having it. You get elderly, you start having joints start getting growths. They start enlarging over time due to the inflammation and swelling over the decades. You get little disc protrusions from the front. Some of the ligaments in the canal start getting, they start growing larger and getting thicker the older we get. And that whole canal just started getting more and more narrow over the years. So little things like a little tear in your disc, a little tear in the joint, a little twinge here, things that maybe when you're younger would cause a little inflammation and swelling back there, not really have much of an effect. You might even notice it. But as that canal gets smaller, you have less and less give. And any amount of inflammation or swelling in that little space all of a sudden becomes a lot more noticeable, and you start irritating those nerves a lot more. And again, if you've been diagnosed with spinal stenosis, and you don't think epidurals are really working, and it's pretty tight around that spinal cord, there's not a lot else you're going to do. Because again, injections, physical therapy, things like that do not change what your pictures look like. That really does become like a surgical intervention type thing. And even if you have spinal stenosis, a lot of times they can open these spaces up without putting any hardware back there. And that's about it. I guess I'd add one more thing, because I know a lot of people have probably heard about it in the past, are these spinal cord stimulators. They do work. I don't believe they're a bad thing to consider if you've exhausted all other things. You certainly would want to try all the other easy injections first. You don't just have neck pain, do a couple physical therapy sessions and then start doing epidurals and ablations and stimulators. You kind of work through it as safely as possible to make sure that something easier and less risky isn't going to work for you. But I would say that there are spinal cord stimulators out there. We really try to reserve those for people who may have already had surgery or not a surgical candidate due to multiple other reasons and has failed all these other options. But this does start to become more of a surgical problem at that point. And even spinal cord stimulators don't fix or change an image. You're just trying to mask the pain. So if you feel like you've kind of done everything I've talked about, you've talked to surgeons and they don't feel there's a good option or giving you a 50-50 whether the pain gets better or not, maybe it's something to bring up to one of your doctors and just see if that's something you'd want to try. Yeah, over time I can see that happening over a chronic issue. Essentially, if you start having neck pain and you start compensating by looking down or looking up to kind of compensate how you're walking or your posture, that can certainly cause a problem long term. And like I said, the longer that goes, maybe it's a muscle pain or something in the beginning, and you start, kind of compensating or looking down or looking up to avoid that. You might start compressing on that joint over the years, longer and longer. And that can just, again, compensation can lead to crazy instances where people start walking differently, carrying their weight differently. A lot of times I'll see people with a lot of back problems, and they like to lean forward to try to take the pressure off their back, try to open up the spaces around their spine, try to take the pressure off their joints. And then over the years, they just keep kind of walking more and more leaning forward, and that forces them to lift their neck up. And really to them, they're walking normal, they're feeling good, they don't really notice as much, and they don't realize how much they're extending that cervical spine and compressing those joints over the years. And you start seeing that. I guess we go back to, we can talk about chiropractor, we can talk about acupuncture and massage. These are all things that kind of fall into the world of physical therapy. You're working on the myofascial stuff. You're working on stretching. You're trying to get that range of motion back. And I'm not sure what this patient's X-rays look like, but you can do all the exercises you want. You can go to the chiropractor and acupuncture, all these things, and work on the muscle pains and try to stretch things out and do the right thing. But if your X-rays show, bad arthritis in those joints, at some point you're just not going to get a lot of relief by focusing on the muscles and things like that. You're really going to have to go and target something and get a therapy that really targets on the joints themselves. There's plenty of studies that show chiropractor, massage, acupuncture, they do have good short-term benefit. And that's why they've all been around for centuries. Physical therapy, again, plenty of good studies showing that if you go and learn the exercises and do them at home and stay consistent with it, there's great studies to show that has benefits 6 months or even a year out if you keep it up the right way. But again, this is why we have other injections and stuff. Like if you have physical therapy for your knee and you have end-stage arthritis in your knee, at some point you start thinking about a knee replacement. If you're still having a lot of neck pain and you've done 3 epidurals, I mean, if you told me the pain going down your arms was still a problem after 10 months and 3 epidurals, I'd say, wow, you may have to talk to a surgeon. You might just be pinching this nerve so bad and irritating it so much that no amount of steroids is going to fix this. However, if you tell me that you still got really bad neck pain, and it's not so much the pain radiating down the arms or not a lot of numbness and tingling, but that pain that's just sitting in the neck, you do epidurals and you put steroids around the nerves, it might help some of the neck pain and some of the joint pain when those steroids leak out and absorb all over the place. But I wouldn't say an epidural is specifically targeted for joint pain. So I'm not sure if this patient has had medial branch blocks. Like I said, you're not going to go in and do these ablations and just hope for the best. You're going to start off with a couple diagnostic tests. You're going to go in. It sounds like he's got bad neck pain. It's for 10 months. He likely has it every single day. He's got a good idea what it feels like if he looks up and turns his neck around. If you go in and numb the nerves that go to those joints, kind of see how he responds. If he feels like he has a pretty good day, I feel really confident saying it's probably more the joints. You might now need to do an injection that targets more that. The neck pain, certainly, like we talked about, can cause headaches. I guess classically what I would say the typical way that people compensate and how I see things happen over time is, if your only problem is a sore muscle or a tight muscle, that's going to get worked out over time. It doesn't usually last more than a couple months. That's why we call it acute pain. If you go to physical therapy, they do the exercises, these things typically go away with time. I think, as you get older, you start getting more and more worn joints in the neck for a variety of reasons, posture, just getting older, trauma, a million things. But you start getting that arthritis in that joint. And then it becomes a little bit more painful to turn your head all the way over or all the way this way. Or, maybe you like, trying to lift your shoulders up because it kind of takes the pressure off by moving your joints just the right way. And when you start doing that, you start losing that range of motion very slightly over time. Again, you don't even notice it. And as you start doing that, you start losing the range of motion and the muscles themselves just are not getting stretched how they used to. And then over time, you start getting a little bit of more contraction in these muscles. Everything starts tightening up. And as these muscles all start tightening up because you're not moving your neck around because it hurts because your joints are worn, then you start pulling on all those muscles and ligaments at the base of the neck. And when you do that, you start getting those tension headaches. You start getting that occipital pain that radiates up and back. And then when you come to the doctor's office and you've had this pain for 10 years and you start having all these different symptoms, you really start teasing out, what's the biggest problem and where to start and where to get the most benefit from.
Thank you very much for participating in the seminar this evening. If you will please take a moment to complete the short poll on your screen, we would greatly appreciate it, and we look forward to hearing your feedback.